part of the second part of the two-part series in medical communication skills. Last time we had talked about the basics of communication skills, primarily active listening. I hope some of that would be there in the recollection. Today we have a lot to cover. Therefore, we'll straight away get on to the presentation part. I'll start the screen sharing. Today, we'll be talking about some advanced communication procedures. I call them procedures because just like any medical procedure, there is an indication for certain communications. There is a standard operating procedure for the same and an expected outcome. So today we are going to cover how to communicate bad news. We'll talk a little bit about it, the various models that we practice, and we'll also try to understand why it is important. What are the benefits of communicating bad news? From there, we will take a diversion. We'll go to collusion management because oftentimes the family, in our culture and our context, the family would come to the doctor and say, please don't tell this to the patient. So that collusion, how do you manage it? And thereafter, we will come back to communicating bad news. This time, the practical aspects of it, how to do it. And last, we'll also deal with a little bit of anger, how to manage anger in the clinical environment. So, communicating bad news is nothing but telling the truth. And telling truth has never been popular, it's never been easy. And therefore, it is something that nobody wants to do, especially when we are dealing with very bad news to be conveyed. And oftentimes, we would rather tell the family member than tell the patient. Therefore, it takes some kind of training, some kind of skill enhancement to tell the truth to the patient. Oftentimes, we practice what we call as non-disclosure model. That is, let's say the patient and the family comes to your OP and you have something bad to convey. And if you ask the patient to leave the room so that you can convey the bad news to the family member, then basically you are not disclosing this to the patient. And hence, it's a non-disclosure model. And this is something that we commonly practice in our environment. And this can get into a conflict with the patient's right to know. What if the patient wants to know? Then we are getting into conflict with the patient's right to know. In some other uh, environments where it is mandatory, even legally binding, to tell the truth to the patient and nobody else. And if you can take the permission of the patient to talk to the family, but first and foremost, you have to disclose the truth to the patient. There are some countries like that. So the practice would be to tell to the patient, and that would be called a full disclosure model. So the problem is that what if the patient does not want to know? Then uh, being forced to tell the patient gets into conflict with the patient's right not to know. So patient has the right to know as well as the right not to know. However, the models that we practice, these two models, which are the common models, are the models of non-disclosure or full disclosure. And both of this gets into conflict with the patient's right. Now, this happens because we are deciding whether the patient should know or not. Uh, Therefore, this conflict. However, if we were to find out what is the patient wants and then do it accordingly, then that would be called an individualized disclosure model. An individualized disclosure model has two parts to it. One, we have to figure out whether the person sitting in front of us wants to know or not. And the second part is, if the person wants to know, then how much. So these are the two important aspects of individualized disclosure model. So we don't decide whether the patient should know or not. The patient decides whether the patient wants to know or not and how much they want to hear. So before we get further into it, let us have some idea of why we would recommend communicating bad news. I would put the caveat that it would be for only those patients who want to know. We are not recommending communicating bad news to patients who do not want to know. So, having clarified that part, if somebody wants to know what are the benefits, most of the time we live our lives as if we are going to live endlessly, including we doctors, and same thing for everybody in society. Therefore, many important things to be done in our lives, we keep postponing it, including writing a will or settling accounts, etc. So, if we have a disease which is incurable, progressive, advanced, and possibly a mortality in the near future, knowing this will help us finish a lot of loose ends that needs to be tied up before we die. That includes, as I said earlier, financial matters. It includes things to be done for children's education, marriage, or the things that we wanted to do. We have always wanted to do. For example, things that, for example, a bucket list. I want to do skydiving, or I want to go and visit Shangri-La, or Machu Picchu, or anything like that. Or maybe it gives you an opportunity to relive your memories, the good memories that you had. Maybe visit some place, uh, anything. It is also time to strengthen the relationship that you have with your family, relatives, friends, colleagues, and also to, in case somebody sinned against you, stopped your promotion, or badmouthed you, or anything, or you had a good friend and something happened and you haven't talked to him or her for past 20 years, 25 years, maybe this is a time to call up and forgive that person or ask for forgiveness if you have sinned against somebody. So there are a lot of things to be done if one knew uh, about tentatively about your own mortality. At least, of course, we don't know when we are going to die, but if we have a disease which is incurable, progressive, advanced, and we see the trend, then maybe that is going to help. Another important aspect is this hospital hopping and doctor shopping business. The patient does not know that what the that his disease is incurable, progressive, and advanced. So, from the patient's point of view, expecting to get cured, get back to normal life, get back to work are very reasonable expectations. But for rest of us who know the reality, they become unreasonable, unrealistic expectation. So the expectation reality mismatch uh, from the patient's point of view, or anybody who does not understand, who does not know the reality, the expectation reality mismatch would lead to dissatisfaction with the best possible treatment that you're giving. And you may be doing your best, but you can do what is realistically possible. And if the patient and the very close people who do not know the reality, their expectation you can never match. As a result, eventually they become dissatisfied. They then go to some other hospital and the expectation rises over there. And then again it breaks down. Then they go to another place expectation rises, the expectation breaks down. Then they go to another stream of medicine, Ayurveda, homeopathy, or to a Babaji's ashram, this and many, many such places. And all this while, they could have been at home with comfort and trying to get things organized, trying to do a lot of things that they could have done. So none of those things happen, and uh, they just go from place to place looking for a cure that does not exist. And this also involves a lot of drain, a lot of financial toxicity, because many times with one patient, two or more family members have to go. Often the earning member may not be able to work because of this. Therefore, there is no income and there is only expenditure. And as a result, you sell off the cow, you sell off the jewelry, eventually you sell the house. The children have dropped out of education long time back. And all of these things leads to a great deal of poverty and hardship. Eventually, the patient dies and the family is literally on the road with no means of survival. So that hospital hopping and doctor shopping could have been avoided or could have been prevented if we healthcare professionals had taken an initiative to tell the truth. Another area is the relationship breakdown. Many a times the family members come to me and without the patient, the family members come and then they break down and cry because they cannot cry at home. At home, they have to put on a mask of normality and behave as if everything is okay. And when they become emotionally overwhelmed, they may run to another room, cry there, or if they live in a very small house, they may run to the neighbor's house or relative's house. And rich family, poor family, all of them come to the doctor's room and cry in front of us. Now, all of this happens because obviously since the patient has not been told the truth, they are unable to express their emotions. There is no option of hugging the patient and crying because the patient has not been told. And eventually the patient dies, and then the family member looks at the photo of the patient hanging on the wall and wishing if only he or she had been there for some more time. The question is, what were you doing when the person was there? At that time, we had put on a mask and playing a drama. And therefore, precious time is wasted in these kind of uh, things. And only if the truth was out there, then real relationships could have been formed. Therefore, these three important aspects which are connected to not telling the truth to the patient is something that we need to understand and remember. Now, many a times it is not just we healthcare professionals who are hesitant to tell the truth. Oftentimes, it's the family members who prevents us from telling the truth. They come to us and beg us, please do not tell this to the patient. They want to enter into a conspiracy of silence with us to keep the patient out of the information loop. So the family members request that let us share this information and keep this information only between us, the family and the medical profession, and keep the patient out of it. They do not mean harm, they mean well, because they are basically trying to protect their loved one, because they perceive that if their loved one came to know the truth, and they believe, not just perceive, they believe that it will harm. And when we challenge their beliefs, it will only make them more anxious and afraid. And they may even refuse to get treated under you and may take the person to some other place if you insist that the patient must be told the truth. Therefore, how to manage collusion? Remember, when we are talking about palliating, we're not just palliating only the patient, we need to palliate the family also. So, right now, apart from the patient, we have family members who are very much emotionally stressed out, anxious, afraid. We need to palliate them. So, the first thing to do is to agree. The family member comes to me and says, Doctor, please do not tell the patient. My usual response is, okay, no problem. And this itself brings down their anxiety, their fear. And sometimes I ask them, what have you told the patient? And they tell me whatever fabrication, whatever lies they have told. And I tell them, is it okay if I also say the same thing? So this brings down their anxiety even further. But that does not mean they have started to trust me. That will take some earning on my part. I have to earn the trust. But right now, at least, I have palliated their anxiety and fear to some extent. Then I see the patient, I do what I can for the patient to relieve their symptoms. And please remember, relieving symptoms of the patient is a great way of earning the trust of your patient's family members. Even if you can't treat the disease, if you relieve the symptom, the distressing symptom of the patient, I would just want to pause here and give you something to think about. God forbid, if somebody who is very close to you is suffering with something, let's say severe breathlessness or severe pain, and you have tried everything possible and still, or your colleagues have tried everything possible and still your loved one is suffering in distress, crying, and if somebody else comes over into the scene and relieves that suffering, wouldn't you start trusting that person? Wouldn't you want to listen to what this person has to say? The same thing happens with all the family members. So learning symptomatology is a very, very powerful tool to earn the trust of the family. Apart from that, all the things that we talked about during our last session of active listening also will help build up a relationship of trust with the family. And once the family starts trusting you, now they will listen to you. Till now, you were listening to them, you have earned their trust, and now they will listen to you. At this point of time, in your journey with your patient and family, at the point of time where it seems that they are listening to you, trusting you, they are asking your advice on everything, including things on in which you don't have expertise, then you can kind of assume that they have started trusting you. At this point of time, we can bring in the topics that we talked about earlier, why it is important to communicate bad news. And this you introduce gradually and over a period of time to a point where they seek your guidance on how to go about it. And often it takes a couple of sessions with the family when they realize the importance of it. And oftentimes in my case, oftentimes I've been asked to convey this to the patient because family member says, Doctor, I cannot tell this to my husband, I cannot tell this to my wife, I cannot tell this to my child, I cannot tell this to my mother or father. Will you please help me with it? Then I say, okay, fine, I will help you out with it. At the same time, I also tell them, you have given me the green signal to talk to your loved one. However, if that person does not seem to be interested in knowing the truth, then I will not force it upon him or her. So this much I convey before I proceed to it. However, uh, reorienting the family despite your best efforts may not happen. They may still cling to pollution. And sometimes this may make you feel a little frustrated, irritated. But please remember, do not push this beyond a point, because then it would appear as if you have an agenda, and this will cause friction in the relationship between you and the family members. Therefore, be prepared for failures, especially if you are new to these communication skills. But as you practice, your conversion rates will improve. But it will never be 100%. The best of the communicators, people who have been doing this for years and decades, we still have failures. So, thing to understand is there is no shame in failure. The only shame is in not trying. So, with every patient who has a bad news and the family is colluding, try collusion management with the methods I just talked about, and gradually you will learn the language of how to persuade. Uh, this is not a workshop, so I cannot, go beyond this. But that is the SOP. Sometimes having workshops and even better mentorship in these areas are going to be really helpful in improving our own skills. So I'll stop it there. Please understand, failures will be there, but keep on trying, keeping on practicing with every patient, with every family. When you practice, gradually the skills will improve. Coming back to communicating bad news, the SOP is called SPIKES protocol. The acronym stands for setting up the interview. P stands for perception. What does the patient know? What is the patient's insight? And then obtaining the permission or an invitation from the patient to share information. And once you have that, then you share the information in a language that people can understand. Uh, no jargon, no Greek and Latin, only normal people's language. And when you share information, obviously be prepared for an emotional reaction to the truth that the patient was not aware of. So we need to learn how to handle that emotion. And once we have drained out the emotion, then we can talk about what can be done, what cannot be done, how to go about it, etc. etc. Why I said we have to drain the emotion? Because when somebody is in a heightened state of emotion, at that point of time, the person will not be in a frame of mind to listen to any rational conversation, including what can be done, what cannot be done. Therefore, it will be a waste of time. So always drain out the emotion and then proceed with subsequent conversation. So that is the spike protocol. And a small medical story. Mr. Bharat, who is a 67-year-old gentleman, was diagnosed as having interstitial lung disease and has been on treatment since past 25 years. It's a progressive disease, and now he is bedridden with refractory breathlessness of about 1 month duration. And recently, patient has not been cooperative with the ongoing treatment, and they have come to you to take a second opinion. And now the patient is admitted under you, and apparently for better treatment. So this is a case story. So let us talk to the patient. So, Mr. Bharat, tell me about what is your problem. I read the reference letter, but I want to know from you. Sir, I have been having breathlessness since 25 years. Initially, I took treatment from my local doctor, and at a later stage, my local doctor referred me to the pulmonologist in the city hospital. And now, for many years, I've been taking treatment from the pulmonology doctor. And I've got good treatment all these years, but recent past, since about 2 years, I think the medicines are not giving me as much relief as they used to, and my health is also going down. And since past 2 months, I cannot even get up from bed. Always I'm breathless, and there's always so much weakness. And the doctor now does not seem to be interested in treating me anymore. And therefore, I came here for better treatment. Now, this could be one of the typical history that you might hear. However, this history is grossly inadequate because we don't know what the patient understands about his situation, about his medical condition. Therefore, we'll have another try. This time, we'll try to dig the patient's insight. Mr. Bharat, come, sit. Tell me, I saw the letter that you gave me, but I want to know from you. Tell it to me from the beginning. Sir, I've been breathlessness since about 25 years. And initially, I used to take treatment from my local doctor. And after some years, then he referred me to the pulmonology doctor in the city hospital. And then he was taking my, giving me treatment and all. Wait. What exactly is your disease? My disease is breathlessness. Okay, go on. Then all these years I have been having good treatment, good relief, but since past 2 years, I don't know why the medicines are not giving me much relief. My health is also going down. And since 2 months, wait. You said that since past 2 years, medicines not giving relief. Why? I mean, what have your doctors been telling you? What is wrong? Nothing. They just tell me to take the medicines regularly. Okay, go on. Now, since 2 months, I cannot even get up from bed due to breathlessness and weakness. And doctor now, I don't know, does not seem to be interested in treating me anymore. Why do you say that? Uh, because doctor is not giving me medicines to make me better like before. And so I came here for better treatment. So if you look at this, if you dig more, the patient has no idea about what the disease is. All that the patient knows is that his disease is breathlessness, though we know that breathlessness is just a symptom. So he doesn't have much of an idea of the disease. And why, since 2 years, medicines are not giving him relief as it used to. There also, there's a blank, nothing. They just tell me to take medicine. And the patient feels that the doctor does not seem to be interested in treating me anymore. And on inquiring about that, because doctor's not giving me medicines to make me better, so his expectation is not matching his lived experience, his lived reality. And all this is blank spot. The person does not understand what is going on, why he's uh, what does he have, and why he's gradually becoming worse, and why now does and nothing seems to be working. So this insight is very important for each of us to know, for each of our patient, whether we are going to communicate bad news or not, because it gives us an idea about the person's mindscape, about what exactly the person understand. And most of our patients will have a lot of blank spots in their understanding of their medical condition. They may have some areas of understanding which is correct, and then they may have some areas of understanding which is absolutely wrong, and a lot of area of not understanding what is going on, that is the blank spots. And we knowing that is important because that information gives us power, and we will talk about how to go about it. So before we uh, uh, go on with communicating bad news, a bit of preparation is good. Communicating bad news is like doing an elective procedure, like an elective surgery. So it is best if you can allocate a time for it when you can spend some time, just like you would spend some time for a procedure. And uh, if you're doing it in your OP, having some paper tissues and paper cups with clean water, drinking water, and all would be desirable. However, if none of that is available, that is also fine. So, first and foremost, assuming that the patient has not been told the reality, before we get on to talking about it, we can explore if the patient wants to know. Now, this may be unnecessary if a patient is is pestering you with, doctor, what is my problem? Tell me what is my problem. What is my problem? Tell me. That kind of a patient does not need exploration, does not need any exploration. This is for a patient who is not asking you anything, who is just sitting there, really not asking questions. Therefore, so once you have dealt with collusion and you have the green signal from the family, you can do a bit of exploration. Mr. Bharat, you told me you continue to feel tired and breathless. Do you wonder why? Do you want to know more about your disease? Yes, yes, I want to know about my disease. So this would be the natural response to an exploration. Sometimes, if the patient is not making eye contact and not looking at you, even when you explore, that means probably the patient has some idea, or maybe we are dealing with some psychosocial stressors, which is making the patient less communicative or non communicative. Usual pattern would be you make an exploration, you get a response like this. And just because somebody says, yes, I want to know, does not mean you start telling the truth. You have to be very sure. For that, you give a warning shot. Mr. Bharat, if it is something serious, would you still want to know? In Hindi, I would say, Mr. Bharat, अगर बात कुछ सीरियस है तो क्या फिर भी आप जानना चाहेंगे? In Malayalam, I would say, Mr. Bharat, കാര്യം ഇത്തിരി സീരിയസ് ആണെങ്കിലും അറിയണം എന്നുണ്ടോ? Basically, you are conveying that it could be something serious and would you still want to know? Now, this warning shot has a couple of purpose. One, the moment you give a warning shot, till now the conversation or the interview has been going on as a normal interview. Suddenly, with a warning shot, it becomes the environment becomes serious. Second important part is you will have a response from the patient. If the patient does not make eye contact, then that means the patient does not want to know. Sometimes there will be no eye contact and the patient may give an excuse. Doctor, just give me a medicine, I'll come after 1 week. So makes an excuse and tries to escape the situation. Or sometimes the patient may look into your eyes and says, no, tell it to my children, I don't want to know, or something like that. Any of this. And if the patient is not saying anything, not making eye contact, then all of these things is shouting out that here is a patient who is saying, I do not want to know. Then do not proceed. However, if here's a patient who looks into your eyes and says, yes, I do want to know, this is after the warning shot, then there is no confusion. Here is a patient who wants to know the truth, even if it is something serious. So, individualized disclosure model criteria 1 fulfilled. You have clearly, unambiguously, have found clarity that the patient sitting in front of you wants to know. Then you can proceed. Do not proceed here. Here you have got the invitation, the permission to proceed with telling the truth. Now, just because the person said, yes, I want to know, you do not tell the last part of the information first. You tell a story. You tell the story of the patient to the patient from the beginning, and while you're telling the story, you fill in the blanks that you found out when you were taking a detailed history of the patient, where you, along with the patient's disease history, you also took the inside history of the patient. So now you know where the blank spots are. You know what does the patient understand. You know what the patient has no clue. Then you tell the story, and while you're telling the story, you fill in the blanks. And while you're filling in the blanks, you gradually escalate the information as you go along. And while you're telling the story, you should focus on the body language of the patient, especially the eye contact of the patient. As long as the patient is maintaining eye contact, you tell the story. At some point of time, if the patients break eye contact, you pause your story. Maybe, maybe the patient found new information for the first time and needs some time, some pause time to digest the new information. And once the patient has digested the new information that you have given, then the patient may look back at you for more information. However, if the pause is very, very long and you don't know what to do, then you can break the pause by asking, do you want to know more? And if you have broken the reverie and the patient again looks back into your eyes and says, yes, tell me, or then what happened? Then you can continue the story. However, if the patient continues not to make eye contact, that means the patient had enough, or at least enough for today. This is how you find out how much information to give, not less, because that will cause dissatisfaction, not more, because it may cause emotional injury, emotional trauma. So by following the patient's body language, you will know when to tell, how much to tell, and when to stop. Stop where the patient wants to stop. So it cannot be your agenda. I'm again using that word again in the context of communicating bad news. You do not have an agenda to tell the full story. You are only a facilitator of information. So let us see how to go about it. So you have explored with Mr. Bharat. Mr. Bharat said, yes, I want to know. You have given a warning shot to Mr. Bharat. Mr. Bharat looks into your eyes and says, yes, I want to know. So we are proceeding from there. Mr. Bharat, you have been suffering from breathlessness since about 25 years, right? So initially you were taking treatment from your local doctor and those were giving you good results. Later on, you said that there wasn't much relief. So he got, he did an X-ray for you. And the X-ray showed something like a shadow. And to know more about the shadow, he had referred you to the chest specialist, the pulmonologist at the city hospital. Oh, I didn't know that. Yeah. In the city hospital, they did a scan of your chest and it showed little damage to your lung. And to know what this damage was, they did those tube tests and all to get a sample from your lung. So I'll just go back. So the story, while you're telling the story, you're filling in the blanks. The first fill in the blanks was something like a shadow. And in the next line, something like a shadow escalates into shadow. It is no longer something like a shadow. It is shadow. And then shadow escalates into little damage to your lungs. And little damage escalates to damage. So this is how we fill in the blanks and escalate the information while you're telling the story of the patient to the patient from the beginning. So here the patient is not saying anything but making eye contact. The biopsy showed that your lungs had a disease called interstitial lung disease, which permanently damages the lungs. You saying my disease has no treatment? I'm sorry. Yes, the disease was incurable from the very beginning. Mr. Bharat, do you want to know more about this? But all these years I was taking these medicines and I was okay. Why am I not getting better now? I'm sorry. Not only is the disease incurable, it is also progressive. As it progresses to the advanced stages, the regular medicines alone may not help. It has been helping you a lot. Your doctors have been giving you these medicines. They were the correct medicines to be taken. But as it progressed, now those medicines are really not helping now. Nobody told me anything all this while. And now the emotions are coming. Or the emotion, when they come, now this is something that doctors are not trained. Don't do anything. Don't say anything. Just be with the patient. Because being with the patient is allowing ventilation of emotion. It is like ascitic tapping. You put in a needle, connect the tube, and then you wait for it to flow out. You cannot hurry it up. But a human emotion can flow only through another human being. And in this case, the other human being is you. A patient who is a human being cannot ventilate emotion on a table or a wall or a desk. The patient who is a human needs another human, that is you, to ventilate the emotion. So, therefore, your presence is the important factor. Your words are absolutely not required. Just be there, sit there silently. Do not check WhatsApp and Facebook while you're there. Do not even look at your watch or the case sheet in front of you. Focus 100%. Even if the patient is not looking at you, the patient can sense what another human being is doing sitting very near to him or her. Therefore, just be with the patient. And usually the emotions will drain out if you're not interrupting, if you're not saying anything, saying some kind words, and all of these will interrupt the flow of emotion. If you're not saying anything, if you're not doing anything, just sitting there, focusing on the patient 100%, the emotion will flow and subside in about a minute or 2 minutes time. But it will feel like 1 or 2 years sitting there. That is because we as doctors are not trained for this. So once the emotions have been drained out, then the person will be in a frame of mind to discuss things. Sometimes patients in state of emotion may say something like, how much time do I have, doctor? Now, when you hear things like that, immediately you should remember, never assume. Never assume. When people say something, they may have reasons for saying that. Therefore, ask, why did you say that? And then they may tell you the reason. My daughter's marriage is fixed after 6 months. Should I arrange it earlier? So here is a person who asked this question, how much time do I have, doctor? Because the patient wants to plan something. But another person who's asking the same question, how much time do I have, doctor? And you asking, not assuming, you asking, why did you say that? The person says, why did God do this to me? So here is a person asking the same question for totally different reason. This person needs more ventilation. So if you have 100 people, they ask the same question, they may have 100 different reasons for saying that. So therefore, as doctors, we should never assume why somebody said whatever they said. Just ask and they will tell you. It's as simple as that. But that is something that we find so difficult to practice, not to assume. It is a very difficult skill. I told about it during the last session also, but this is very important, and it has a lot of significance when we are dealing with high stress situations like communicating bad news. Once all this emotional reaction has subsided, then we can talk about what can be done, what cannot be done. And here, your knowledge in symptomatology, which you are learning as part of your training program in palliative medicine, is going to kick in. It will help you out. Remember, with palliative medicine, there is no situation where you have to say no, nothing more from my side, irrespective of the diagnosis, irrespective of the stage of the disease, curable, chronic, uh, terminal, there is no situation where we cannot provide relief to the patient. Therefore, we should always give hope, but it should be realistic hope, it should be achievable hope. And we talked about practicing management, decision making through participation, and all of those things is something that we will do after all the emotions have been drained out. So this is where we stop. Uh, so this is an example of realistic hope. Even though your disease is now advanced, we will ensure that you are comfortable. That can be easily done, and you are welcome to come back to us anytime you want. So this is just an example of giving realistic hope. Now, since we are running short of time, I'll move on to managing anger in a clinical environment. We are all aware of the unfortunate incident that happened recently, and I want to clarify. I am not talking about a law and order situation.
I think Dr. Biju Raghavan's connection has been gone. We will wait for a few minutes. He will be joining us back.
Clear? I'm talking about how to manage anger in the clinical situation, not law and order situation, because we are not trained. We are doctors. We are not trained in law and order. So if it's a law and order, run for your life, run away from that situation as fast as your legs can carry you. However, many times we see angry situation developing in the ER, ICU, outside ICU, and even outside our OP areas also. And people get angry for various reasons. But first of all, please understand that normally people don't wake up in the morning and plan to get angry. People get angry because of various stressors. First of all, being sick and not well, or having a loved one who is sick and not well, that's a stress in itself. Day-to-day life stress, livelihood stress, traffic stress, reaching the hospital on time stress. When you reach there, not getting an appointment, not getting token, or having to wait for a long time while you are sick or your loved one is sick. All of these are stress builders, and eventually something happens, and somebody loses their cool and starts burst forth like a pent up lava. So all of these are the etiology of an angry situation, and usually it is more than one reasons why somebody gets angry. And you may not be the reason for the anger, but oftentimes you may be the recipient of an angry situation. Therefore, to understand anger, I'll start from right. It's an emotion. It's a negative emotion, but so is crying. Being sad is also negative emotion. However, the distinguishing feature is anger consumes a lot of energy. It's a high energy consuming negative emotion. Therefore, to get angry and to stay angry, a lot of fuel is required. And the fuel can come in two forms. One is if you ignore the angry person, Oftentimes, when somebody comes to the reception and the reception people are not making eye contact, not smiling, and that person waits for a long time to get a eye contact from the person in the reception. I'm just giving an example. So this ignoring or perceived to be ignoring or poor communication skills on the part of the person in the reception, all of these things can fuel somebody's anger. So ignoring a person can produce anger, it can sustain anger, it can increase anger. The another category of fuel is confrontation. Confrontation can be in the form of arguing with somebody. Argument is a confrontation. For an angry person, giving an explanation or an excuse also becomes a confrontation. And for somebody who is very, very angry, extremely angry, even an apology can make the person more angry. So, depending on the grade of anger, an argument can produce anger or sustain anger or escalate anger. Uh, Giving excuses or explanation to a very angry person may increase the anger. And somebody who's already very angry, extremely angry, apology may also increase the anger. So these two categories, ignoring an angry person or confronting an angry person, will both create more anger. Therefore, we have to find a way of safely allowing this emotion of anger to drain away safely and as fast as possible. Therefore, like any situation in communication, body language is of paramount importance, but the importance of body language is maximum when it comes to dealing with anger. So here is an angry person outside your OP. You can, before you see this person, you can hear him. Loud voice, angry voice, high pitched voice, and the content of the voice would be unparliamentary language, maybe even questioning your genetic material. And along with it, when you open the door, you see here is this person with an angry face, eyes bulging out, the teeth bared. And this person will not be sitting in a lounge. This person has so much adrenaline in him that this person cannot sit down. A very angry person cannot sit down. That angry person will be standing or walking around, pacing around. So, this is an angry situation, the diagnosis of an angry situation. What do you do? Go back to all the body language things we talked about last session. The moment you see somebody is angry, whether you're a doctor, you're a receptionist at the reception counter, or the nurse at the nursing station, whoever you are, stand up. Because when you stand up, you equalize the eye contact. The eye contact is equal. So this is creating a sense of equality. I see you as my equal. Suppose you are the doctor and you are sitting on a chair and this angry person is standing opposite to you across your desk. When you look up, your gaze is upwards, that person's gaze is downwards. It is clearly creating hierarchy. You, the doctor, being the powerful person, you are creating hierarchy. And this discrepancy in the gaze, the discrepancy of height in the gaze, will anger the person more. And it is just about time the person will climb on your table to do more harm. Therefore, stand up, make eye contact at level, and create a sense of equality. This is the message you are conveying through your body. A slight kyphosis, whether you are sitting or standing, last time we talked about, when you create a kyphosis, You are conveying to the person in front of you, I am here to listen to you. It is also showing I respect you. I respect you, that's why I listen to you. Then keep your hand somewhere where the angry person can see. Remember the fight and flight response, an angry person is also a scared person. Fight and flight. So, therefore, showing the hand is a primordial response across the world. When you show a hand in the form of namaste or in the form of salute, whichever way, when you show a hand, you are conveying, I do not carry weapon in my hand. I come in peace. I do not mean to harm you. So this also is a way that the person's brain, the angry person is not understanding any of this consciously, but unconsciously you are giving a lot of positive signals to the angry person's brain, because of which the fight and flight response is coming down. So you stand up with a slight kyphosis with a hand where the person can see. Now let's come to your face. You maintain eye contact. When you make eye contact, you are not ignoring the person. You're also conveying that I am confident. Have a normal eye contact. Do not stare. Do not see the person from the side angle. Just see the person right from the front. Do not smile, because smile will be seen as confrontation. Now, this is the only situation where I will say do not smile. So keep your face serious, because you want to convey you are taking this person seriously. Then I also told last time, to encourage somebody to talk, you make eye contact and you nod your head. I also said you can make sounds like aha, go on. But here you do not make a sound. You do not make a sound. You do not say anything. So this is, I'll repeat, the moment you see somebody who is angry, you stand up with a slight kyphosis, keep your hands in front, do not put them in your pockets or behind your back, keep them somewhere, you can let it loose hang by your side or keep it in front. I make eye contact, keep your face serious and nod your head. Doesn't matter what rubbish the person is saying, because here you are trying to make sure that this emotion is ventilated safely and as quickly as possible. So you are neither giving any of the fuel, you are neither ignoring this person, you are neither confronting this person. And because of this, the high energy anger, the high flaming anger will come down very, very fast. It will hardly take a minute or two. All the time you will be having palpitation. Whenever I have done it, I have experienced palpitation, but you keep a face, you can behave brave while feeling scared inside, and you will convey bravery across to the person. You will convey confidence. So it doesn't matter you are having palpitations, you just maintain this posture, and thereafter you will see that the within a short period of time the high flaming anger will come down. However, there is a simmering anger which is still present, and that can, anytime flare up to high anger again. So how do you diagnose this? You will see that the bad words have come down, the high pitch is gradually coming down, high volume is gradually coming down, and now the person is talking more of a complaining nature rather than of a threatening nature. So this is the diagnosis that the high flaming anger has come down to a simmering anger. At this point of time, for the first time, you can open your mouth and say something like, Sir, I want to know more about this. Can we sit down somewhere and talk? Basically, you are conveying your dil mange more, and you are inviting this person to come somewhere and sit and do this to you more. Now, why is this important? Because here was this person who was very, very angry in a public space. And everybody in that public space would have stopped doing whatever they were doing or going somewhere. They would have just stopped in their track and they will be mesmerized watching this person shouting in anger. And remember, most of the people who are in the hospital, they are all stressed. They are either patients or they are family members of the patients. So it is very easy for this anger to get infectious and make other people also angry. And soon, within a short period of time, you may have a mob of angry people in that public space. Therefore, once you have drained down the high flaming anger, removing this person from the public space into a private space, into a room somewhere, is of utmost importance. But you cannot move this person when that person is in high anger. Because if you suggest, can we sit and talk somewhere, that will be a confrontation. It will make that angry person more angry. So reduce the high flame to simmering flame. Then ask this person, can we sit down somewhere and talk? I want to know more about this. So this way you are able to remove this angry person from the public space and potential danger to us and to our institution into a private space. The moment this person is taken out of the public space into a private space, the public space will become normal. People will go around to wherever they were going. People will go back to whatever they were doing previous to this. Everything will calm down, and that way we have averted one danger. Now, taking this person into the private space, we allow this person to ventilate his emotion even more, but this time sitting down, and you are also sitting down in front of this person. It is preferable you do not bring a table in front of you because that creates a barrier. So just pull up a chair to the side of your table if it is your room so that you can see this person and the person can see you face to face. In sitting position, sit with a slight kyphosis. Keep your hands where the person can see, either on your lap, on your knee, or on the table side of or the side of the table, and then let the person continue to ventilate. You make eye contact, keep your face serious, and keep nodding your head. So this will result in the person ventilating all the stress that this person was experiencing. Please remember, anger is just a manifestation of stress of multiple etiology. You end it with or without an apology. If apology is merited, do give a sincere apology, but do not give a, a heck of for the heck of it an apology. Do not give an insincere apology because it can reignite the anger, or if nothing else, it will leave a bad taste in the mouth. If there is a solution to the person's problem, you can give a solution, but if there is no solution, don't make a false promise of solution either. So example of ending it well. Thank you for bringing this to our notice. We are very sorry you had to experience this. So this is ending this by offering an apology. Another way of ending it is thank you for bringing this to our notice. This is what we are going to do. I am going to talk to the operations manager and give the instructions so that something like this doesn't happen again. So this is another way of ending it. To finish off all the 3 points that we talked about today, which is communicating bad news, collusion management, and anger management. When it comes to collusion, the most difficult of the skills that we talked about today, listen to the family. That is the starting point of managing collusion. Whether you succeed or not, when it comes to collusion, always try to win the trust of the family and thereafter convey to them why it is important to communicate. Failures are nothing to be ashamed of, and the more you try, the better you become. Your conversion rates will improve eventually. When it comes to communicating bad news, or simply put, telling the truth. You do not have the role, you do not have the duty to tell the truth. It is for the patient to decide whether they want to know or not. And the patient will decide if they want to know, how much they want to know. Our role is that of facilitator of information. Whether it is crying or anger, both are emotion, and ventilation of emotion is a therapy. It is a very, very important therapy in clinical psychology. But as doctors, we are not trained to do it. Definitely, it's not a waste of time. It will help us protect ourselves and our institutions and also build up a rapport with the patient and family. Specific to anger, non confrontational ventilation of emotion is one of the easiest skill to master. Remember, it's all done with body language, not with words, not with your mouth, with your body. So, with that, I finish. I stop here. I'll be happy to take questions, or I hand the baton back to Raj Lakshmi, our host, and let her decide how we should proceed.
Thank you, Dr. Biju, for that wonderful session. I think we can take questions now, sir. Dr. Shah Jahan, you have a question to ask? Sir, you're
Question.
mute.
Actually, this is a wonderful session with regard to discussing to the patient. Actually, what we used to, all these points, to somehow we used to talk with the bystanders, not to the patient directly. So to the bystander, we will ask, do you want to know what is it? Do you know what is the diagnosis of your relative like that? Almost all the points Dr. Biju has narrated, we used to discuss with the caregivers, not to the patients directly, often. So that's a good learning point. Thank you.
Thank you so much. Interestingly, collusion is very, very common. And I still remember there was a very, very senior politician in Kerala, and his personal secretary uh, was having interstitial lung disease, I think, a very advanced state. Not the politician. I'm not talking, I'm not revealing who the politician is. His secretary and his daughter came to me and said that we have not told Papa what the disease is. Please do not tell him. So it is not just cancer, it is people, family members come to collude. Don't tell about the cardiac problem, don't tell about the liver problem, don't tell about the kidney problem. Collusion is not specific to any diagnosis. Family members come and say, and therefore, many times that also is a reason why most of the time we do not talk to the patient about it. But yeah, as you said,
But
today's session was.
what can actually what can we do with that? Suppose the family members are telling. Suppose we are dealing with the ILD often. Suppose the family members are constantly saying us, "Sir, please do not tell us. Sorry, please do not tell. Please do not tell." So how can I ask directly to the patient? Because in a government hospital or most of the hospital, the bystander is always almost with the patient, unless the patient is in ICU. So what actually we can do?
No, we should not be talking, we should not be telling the truth to the patient without the consent of the family. Because in our culture, the patient's
Yeah,
autonomy
that's
is subservient to the rights of the family over the patient. In our culture, patient autonomy is not sacred. It is like more of a issue in the Western culture, where the patient autonomy is so sacred that you cannot talk to the family without the permission of the patient. In our culture, it is just the opposite. You cannot talk to the patient without the permission of the family. Because in our culture, the patient does not come to the doctor, the family brings the patient to the doctor. And hence, in our culture, we have to have the consent of the family before we can talk about this to the patient. Now, this is also important because it involves our safety also, because all of these issues are related to patients with advanced medical condition. and we know that the patient with advanced medical condition will eventually die, and we can't predict when the person will die. I mean, for example, a patient with ILD can die of a cardiac arrest also. And God forbid if that cardiac arrest happens after we tell the patient the truth that this is your condition, and then the family member can blame us that you told, therefore this person had a cardiac arrest and you are responsible for causing the death. So therefore it is very, very important to have the family on our side, proceed only with full green signal from the family. That is why collusion management is very, very important. It's a huge challenge. Many times, the patient sitting in front of me in my OP may be asking, Doctor, what is wrong with me? Tell me what is my problem. And the family member standing behind will be showing. So you are kind of between these two, competing requirements, where the patient is saying, I want to know, and the family members is telling you from behind, don't tell. So we have to deal with that, this kind of situation very often, very, very often. So then we try to buy time from the patient, because it is never black and white. There is a whole shades of gray in between, in which you can operate. So I usually tell the patient, like, I need more information about your medical condition before I can talk to you. And am I telling a lie to the patient? Am I telling the truth? It's a interesting thing. Am I lying to the patient? Mm, no, because I know the medical part of it, but I said I need more information. The information I need is, will your family member ever agree? I don't know. That information I don't have. I do not know when they will agree or if they will agree. So that information I need before I can tell this information to the patient. In that sense, I'm telling the truth. I'm not telling a lie. Information does not mean only the medical situation. We need information about the financial situation. We need information about the logistical situation. We need so many information in our dealing with our patient and family. So I'm not telling a lie. At the same time, I'm, like, not being very truthful, in the sense that, of course, I know the medical condition. Of course, the patient is asking for medical condition, but it is that gray area. I can justify myself. You can argue against that. You will be right. I can argue against that. I will be right. So that is the beauty of a gray area. While I will continue to provide good symptom control for the patient, so that he or she is comfortable and peaceful, not suffering. And while along with it, I'll be with the patient's family member, trying to counsel them, trying to get them into a situation where they would come to a point where they will see the merit of it. At the same time, it will not appear that I'm pushing them into making a decision. I will make it appear as if it was their idea, that it is better to talk to the patient about the truth. So that is a skill that we, develop over a period of time, and making them feel that it was their idea, not my idea.
Thank you, sir. So we do have a question in the chat.
Yes.
So can I read it out?
Yes, please.
So most of our advanced cases of COPD and ILD end up in ICU requiring incubation and ventilation. Patient doesn't want mechanical ventilator, but family insists how to deal with the situation.
Excellent. Now, this is something that, as a palliative care physician, I do it on a regular basis, multiple times a day, not just for people with advanced respiratory medical condition, but advanced other organ issues or advanced cancer. Now, this is something that, whenever I'm speaking to the family members about counseling them, first of all, as doctors, we understand that a disease is incurable, progressive, advanced, uh, is unlikely to benefit from critical care. So what I tell the family members is that, what is your opinion about getting your mom or dad into ICU? And oftentimes they say, well, I don't know, doctor, you tell. I mean, you are the best person. I'm just telling you the just you know the usual conversation. So I tell them, see, ideally, if somebody has a disease, uh, you know, and where the person is critically ill, then ICU and critical care would be right thing. Question is, we need to understand what is critically ill and who is a critically ill person. Somebody who can die just immediately, but if we can somehow uh, I'm used to saying this in Malayalam, so I'm just trying to find words. So if somebody who is critically ill, means that person can die, and with a disease or an injury which can be cured, which is curable. But right now it is so severe that person can die. So in this situation, if we can provide critical care, we will get some time. We provide artificial life support. We get some time. The treating doctors of that particular disease or injury will get some time, precious time, to correct that disease so that this person can come back to normal life. Once that is achieved, then this person can be removed from artificial life support and that person can get back to normal life. However, in doing this, we have to torture that person a lot. And if you were to do the same thing in a police station, you can file a case against that person for human rights violation. But here in the hospital, in an ICU, we have to torture a person a lot in terms of multiple pricks for investigation. We have to put a tube and we have to do all of that. We have to sedate that person to make sure that the person is not experiencing the distress of all of this. So a lot of torture goes in, but we are able to justify it because we are trying to save a life. Hence it is ethical, and because we are trying to save a life, it is moral, and it makes medical sense to do it. It is evidence-based medicine. However, if somebody has an incurable, progressive, advanced medical condition from which the person is going to die anyway, but that person cannot be brought back to normal life, then how do you justify pushing this person into ICU, providing critical care, and torturing this person? You should not be doing this to your worst enemies, let alone your loved one. And therefore, we should do everything to make this person comfortable. But at the same time, you have to ensure that you prevent this person, your loved one, from going into the ICU. Then they will say, then what can we do about it? I said, it is simple. There is a form. You can just sign it, and then your mom or your dad will not be pushed into the ICU. At the same time, the things that is going to help, for example, antibiotics for infection, oxygen, medicines for your breathlessness, or whatever, all of these things which can be done in the room will be done, should be done. And therefore, how much time this your dad, your mom has with us, everything that is going to help the loved one can be done, at the same time protecting from futile, harmful, aggressive medical intervention. So when we convey it like that, most of the time family members say, yeah, that is what we want. Now this is when we are dealing with a situation where we have to take a decision about pushing the patient into the ICU or not. So this 10-15 minutes of counseling can change the thought process 180-degree, and people will. But better is, when you are all consultants, the better is to prepare the family members for this eventuality beforehand. You can have the same conversation that I just talked about, the the benefits of ICU for somebody with a curable medical condition, potentially going to die, you torture that person and you get that person back, all great, versus somebody with an incurable progressive advanced medical condition where that person is going to die, but maybe 1 week from now, maybe 2 months from now, or maybe 1 year from now, doesn't matter. So preventing that person from ICU and critical care, preventing that torture for a terminally ill patient. So you differentiate between critically ill and terminally ill. And then you tell this person, at any point of time in future, when you come to the hospital into the ICU, you tell three things to the doctor there in the ICU, doctor there in the casualty or ER. You tell them, doctor, we know everything. We have been told by our consultant doctor. We have been told by our pulmonologist. We understand everything. Second point is, please do not push this person. Please do not send my loved one into the ICU. Third, I will sign anywhere. So I tell these family members, you remember these three lines. Doctor, my pulmonologist has told me everything. We understand everything. Second point, please do not take my mom to ICU or my dad to ICU. Third, I will sign anywhere. And you can rest assured that will not be done. So this is how we train the family members also how to deal with an eventuality. Because usually when somebody is brought to the casualty, everybody is emotionally very upset, very high. They don't know. So until unless you teach them how to approach this, then you are giving them a plan how to approach it. Then everything will be smooth. Life will be easy for your casualty colleagues also. It will be easy for you also.
Is it advisable to say now the situation is in the God's hands? Let us hope for the best, like that, involving God into the context.
Sometimes, thank you for that. Sometimes it can be a bit tricky because we don't know uh, whether the family member are much into God or not. We don't know if they were into God, but now they are against God. We don't know the status, right? So, and asking them what is your status regarding God would be rather,
Yes.
not advisable. So, sometimes in my conversation, when I am dealing with a family member who is, they understand, but they're finding very difficult to come to terms with it. I say something like, if you believe in God, you can take it as God's will. If you don't believe in God, then you can take it as laws of nature. And whether God's will or laws of nature, this is the way things are. And if you fight against God's will or laws of nature, nobody has won against God's will or against God's or against laws of nature. We'll only end up causing suffering to our loved one. So in those contexts, I bring. So somebody who is a firm believer, when people believe in God, but oftentimes they are not very willing to go along with God's way. So I'm not saying are you a believer. When I say if you believe in God, you can take it as God's will. If not, you can take it as laws of nature. When suppose you are scientifically tempered and you are not much into God, so these two options are there, and majority of people are uh, God fearing, God believing. So not assuming that there, when I say if if you believe in God, you can take it as God's will. So that kind of reorients them that having a belief is one thing and accepting God's will is totally another thing. Because people claim I believe in God, but if we say this is God's will, no, we'll see, we'll check out another doctor, another hospital. so so these kind of things are sometimes do come up. And another situation where sometimes God comes into my dealing with patient and families, if the patient or the family members brings in God. I mean, why is God doing this to me, or why is God done so much to us? And obviously I'm not an expert in God, so uh, you know, I use non-verbal body language, something like, and so I don't say because I don't have anything intelligent to say about that. So I just use various kinds of body language. For example, depending on the situation, I may do this, or I may do this, or I may do this in agreement with their angst. So, body language is something that you can use extensively in your interaction with your patient and family without saying any words, because words, when you say, then it is, kind of, you have committed to it. Body language, you can be little ambiguous, at the same time, be empathetic, be sensitive, and all of that.
Thank you, sir. I can't see any more chats. I think everything is clear by now.
I don't know whether I said it during last time. Our medical education cheats us. It only teaches us diagnostics and therapeutics. It does not teach us symptomatology, communication skills, or medical ethics. Diagnostics and therapeutics is, of course, important, but symptomatology is very important, because if you are able to take away the physical suffering of a patient, the patient is devoted to you, the family member will also be devoted to you. And communication skills is something that is going to save you time, energy, effort. It is going to make your life safe and easier and get things done according to the way you want it. So, five important things out of communication skills. And medical ethics will be a guiding light of how to deal with complex medical dilemmas of whether this is right or that is right. So, good sense of medical ethics, where you understand the concept of autonomy, beneficence, non-maleficence, and justice of time, resource, energy, everything. So, if these concepts have been taught to us as intensively as they taught us rest of the other things in medical education, probably all of us would have been better off. We wouldn't feel so handicapped and helpless in our practice. So, Rajlashmi, are we winding up?
Yes, sir. We can wind up. Thank you, sir, for that wonderful session. Thank you all
So,
for
thank
joining.
you for this opportunity. Thank you, all of you, for patient listening. And thank you, Dr. Shahjahan, for your active participation, and others also for putting in their in the chat box. So, it's been a pleasure. And feel free to contact me on any communication related issues. My number is there. You can WhatsApp me. A lot of people do. I stay in touch with many people like that, so I'll be happy to hear from you. And I'll once again thank Palim India for this opportunity for this session, and
Thank you
it's
so
good
much,
night
sir.
from my side.
Good night or happy weekend, sir. Thank you all. Bye.
Thank you.